Blood sugar regulation. This is Jack Brook from Columbia Gorge Community College, and in this session what I'd like to look at is mechanisms that affect blood sugar regulation, or what we might consider blood sugar homeostasis. And we'll look at diabetes and hypoglycemia and some of the aspects that affect these conditions. So first of all, looking at the definition of diabetes mellitus, it's just a group of diseases that have high blood sugar. So hyperglycemia would be high blood sugar, but also you have incidences of glycosuria, which is sugar in the urine, and then some other aspects that are affected by having the high blood sugar. And the reasoning behind it is either not producing enough insulin to take care of the sugar in your blood, or the cells not being able to receive the insulin or the instructions from the insulin to take sugar out of the blood. So we'll look at those in detail as we go through. Just as a matter of introduction, looking at some CDC websites and some maps that they have about diabetes, looking at 1995, what you can see is, if we specifically concentrate on Oregon, we'll see that it was less than 4.5% incidences of diabetes in 1995. We get to 2000, we notice it goes up to between 4.5 and 5.9% specifically. And then when we go up to 2005, we see it gets up into the range of 6 to 7.4%. And then the last one, 2008, it hasn't changed that much, still between 6 and 7.4%, but it is rising. You'll notice that in the south of this country, it is very high, upwards of greater than 9% incidences. A lot of it having to do with type 2 diabetes, plus a growing Hispanic population. That Latin population has a high incidence of diabetes, but also obesity can lead to type 2 diabetes, and obesity trends are very high in the south of this country. If we look specifically at Oregon, I just got this off the CDC website, we'll see that most of you are from either Hood River County, Sherman County, or Wasco County, and we can see it's pretty close to 7% diabetes in Oregon. So we're up at that upward range where it may get over that 7% range within the next year or two, and maybe now, because the last data was 2008, so we'll see. Just again, some graphics looking at how diabetes has increased in Oregon from 94 to 2005. You can see there is about a 2% increase, and it continues to rise in our population. As far as obesity, we're going to talk some about how obesity affects type 2 diabetes. We'll see that Wasco County has the highest percentage of obesity, and then going down to Sherman County a little bit less, but we're still upwards and closing in on 30%. National average, is upwards of 35 to 40%, so we're not that far behind in obesity rates. And then this graphic deals with diabetics who are overweight. As you can see, that's also increasing from over 80% now in 2005, so it's probably higher than that as we speak. Just looking specifically now at diabetes mellitus, what I have is just a graph that shows what the normal blood sugar levels should be between 70 and 100. It's gone down over the last few years. They've changed the standards. But the graphic, as you'll see, the black line in the middle is the renal threshold. So this is the threshold at which the kidneys can hold the sugar back and you don't dump it. And Anything over that renal threshold is you're going to have glycosuria, or sugar in the urine. It's different for different people, but on average about 170 milligrams per deciliter on that. And this is the normal curve. So if you look at the bottom, basically is what would be considered normal, in that, you know, after you eat, if we start 100 after you eat, your blood sugar level should go up, and then it should come back down and maybe go down a little bit, but then come back up and kind of fluctuate all day long. If you eat, it goes up and continues to be up in this plus range, then you will be considered hyperglycemic, and you will the risk of glycosuria, which are the two incidences that would determine if you have diabetes or not. If you're hypoglycemic, then you would go down, keep going down below 50 and down into 40 range, and that would be hypoglycemic in that range. So this is just kind of an indicator of, you know, we need to be within this 70 to 100 range is what we're hoping for. And then anything over that, up to 129 or so, is pre-diabetes. And then above that, we'd get into the diabetic range. As far as control mechanisms, I want to go over some hormones that are going to affect blood sugar regulation. The number one that you probably heard about is insulin. Insulin is produced by the pancreas, and I'll show you the next slide where the pancreas is, by specifically the beta cells of the pancreas. And the function of the insulin is fourfold. The main functions is that it's going to cause the cells to increase absorption, and I'll show you how that occurs. It's also going to prevent the liver from releasing glucose from the glycogen that we talked about in the heart, in the carbohydrate section, because if you've got high glucose in the blood, there's no reason to have the liver put more in. If the liver glycogen is lower and you're able to put more glucose into the liver, then you'll form more glycogen for storage. And then fat is going to be prevented from breakdown, because you can use the sugars as an energy source, and you don't need the fat, which is one of the premises of the Atkins diet, is that high carbohydrate foods would increase insulin levels, therefore decrease fat breakdown. So if you eat less carbohydrates, you'd have more fat breakdown. But the Atkins diet overall is not a real reliable diet. It's not a good diet. It's not a healthy diet. You do lose weight, but it's not considered a healthy diet. Looking at the pancreas is just behind the stomach. So the stomach would be right here, and so just behind that is where the pancreas is, and within the pancreas you'd have the beta cells that's going to produce the insulin, and it's going to secrete it into the blood system, and then the insulin is going to go to the cells. Now, where the insulin goes are to receptors embedded into the plasma membrane. So this blue line is the plasma membrane. Here's the receptors, and what the insulin does is it fits into the receptor, and when it fits into that receptor, it sends a signal to the cell to produce a transporter. In biology, you should maybe, if you've had biology, and hopefully you learned about active transport. And active transport, you need a transport protein in the plasma membrane to do that. So the cell will actually make these transport proteins. They will embed them into the plasma membrane, and then glucose will be taken out of the blood into the cell, and eventually make glycogen out of them. So maybe you thought that insulin took glucose out of the blood. No, insulin is a hormone. Hormones tell cells what to do, and so insulin is going to tell the cell to make a glucose transporter. All right, and so here's the receptor, here's the transporter, here's the glucose. When the transporter is embedded in the plasma membrane, the glucose is going to be brought in by active transport into the cell. Now this next picture kind of shows something additional in that here's the insulin fits into the receptor. Here's the transporter. The glucose comes in and basically end up, as you can see, making glycogen there. There are several types of transport proteins. You don't really need to know these, but you can tell where they are. You can tell where GLUT2 is in these cells. GLUT3 is here. GLUT4 is in your skeletal muscle. GLUT5. So there's different. These are all transporters, but they are in different cells for transporting glucose into the cells as an energy source. Amylin is a hormone you may not have heard of. It is very involved in glucose regulation, though. It's co-secreted with insulin by the beta cells. So when insulin is secreted, it's also secreted. It has three functions I want you to know. Suppresses glucagon. We'll talk about glucagon next. That actually causes glycogen to break off into sugars. Slows the amount of food that's emptied out of this stomach contents, so it slows the emptying time of the stomach, so it makes you feel fuller longer, and then that's going to increase satiety, and satiety is the feeling of fullness in your body. So it's going to work with insulin to make sure that we don't have a lot of sugar coming into the blood and basically causing glycogen to produce sugars to be put into the blood. So here's amylin here, and amylin is going to be secreted by the pancreas and basically work on the liver and on the stomach for gastric emptying time. And this just shows again that you have a negative glucagon there. Glucagon is produced by the pancreas, but the alpha cells of the pancreas. So again, the amylin and insulin produced by beta cells. Glucagon is produced by alpha cells, and its job is to respond to low blood glucose. Insulin and amylin respond to high blood glucose. So glucagon is responding to low blood glucose, and its main job is to maintain homeostasis of the blood. As you remember when we were talking about carbohydrates, we said glycogen was stored in the liver to maintain blood glucose. So when the blood gets low, then the glucagon can be secreted, and it can basically tell glycogen to break off sugars and put those sugars into the blood. So it stimulates liver glucose release and helps maintain homeostasis of the blood sugar levels during fasting. And here's the idea. Here's glucagon. It also fits into a receptor. It's produced by the pancreas, as you see. Fits into the receptor, goes through the process, and it's just a long process here of taking the glycogen and producing glucose out of the glycogen. And then that glucose is going to be put into the blood because we have low glucose in the blood. GLP-1 or glucagon-like peptide 1 actually secreted by L cells in the intestines. And it's secreted before, when the nutrients are in the intestines, then one of the main jobs of the GLP-1 is to inform the pancreas that there's food there, and especially carbohydrates, and it needs to start producing some insulin. And so that's why it says it stimulates insulin secretion, suppresses glucagon, slows gastric emptying time, so it increases satiety, increases beta cell mass. So basically it's kind of like working out your muscles. The more you work out and produce GLP-1, you're going to increase beta cell mass, to a certain extent. You don't want to go crazy, but you increase that mass so it's available, and then also increases the efficiency. So it has a lot of things that it does in concert with insulin and amylin and so forth. So here's where the GLP-1 is, and it comes from the intestines, and then it goes and stimulates the pancreas for amylin and insulin and so forth, and decreases glucagon. So there's a concert, or several hormones that are all working together in concert to affect blood glucose levels. Any one of them that is affected then could lead to irregulation of blood glucose levels, and that can cause a problem either with diabetes, or hyperglycemia or hypoglycemia. Epinephrine is another one. It's basically not released by the pancreas. It doesn't deal with the pancreas, but it deals with the adrenal glands, especially during high stress. And fight or flight response when you get cornered, or you're in a state of fear, and it wants to increase your heart rate, so you get away from that, either run or fight kind of thing. But there's a lot of things that can cause an increase of adrenaline. And again, we talked about the stress or fear, illnesses, surgeries. So if you are a diabetic, that becomes, if you're sick or something, that can have an effect on blood glucose, because if you're increasing glucose, you become hyperglycemic, and that can be a problem. But also, too much stress and too much adrenaline can also lead to hypoglycemia. And so we'll talk about that a little bit later. So, epinephrine is supposed to be for very short term. It's supposed to be fight or flight, real quick response. So you either get out of there or fight and get it over with. But over long term, if you're under fear or stress for long periods of time, then it can have an effect on hypoglycemia. And this just shows where epinephrine, because of stress, is going to have a similar response as glucagon. Fits into the receptor and then has the glycogen turn into glucose and fuels for fight or flight kind of thing. But again, it's supposed to be very, very short term, and long term it can have some other adverse effects that we don't want. Okay, clinical manifestations of diabetes mellitus, hyperglycemia. Hyperglycemia, they have a new diagnosis now called prediabetes. It's been around not too many years, but they will test it because the feeling is if we can catch it early, we can prevent diabetes from occurring. So impaired fasting glucose of 100 to 125 milligrams per deciliter. Impaired glucose tolerance, which basically means you're going to be doing a glucose tolerance test with a kind of a thick sugar substance that they take blood tests on a periodic basis over hour or two. And so fasting would be you haven't eaten for a while, for 12 14 hours kind of thing. So that's prediabetes. And so if you are pre-diabetic, then you are going to the physician is going to counsel you on possibly losing weight or something before it gets worse. Now, the diabetic range is anything over 125 milligrams per deciliter for fasting, and then over 200 for glucose tolerance. But another one is called the A1C test, or glycosylated hemoglobin of 7%, which basically has to do with how much glucose is embedded into the red blood cells, and gives you kind of a 3-month average of your sugar levels. So glucose tolerance test, again, you'll take some heavy sugar material, and then they'll test your time over 2 hours and check and see if your blood sugar level goes up and then stays up. And here's just an example of glycosylated hemoglobin, where you basically have sugar attached to your red blood cells, and that's an indicator, because red blood cells live, well, not live because they're not alive, but they stick around for about 3 months. And so the more blood sugar you have, the more sugar you have in your blood, the more it's going to stick to the red blood cells, and they don't unstick. And so basically you can look at a 3-month average that will tell you how you've been doing with your blood glucose levels with that. And here's just another picture that just shows that you've got this sugar attached to the red blood cells. Another clinical manifestation is diabetic ketoacidosis, where you can get acidosis or high ketone levels, and so inappropriate or where you're not burning the fat effectively or efficiently, you'll get too much ketones, which will become too acidic, and you can get ketoacidosis from that. And ketone bodies are basically, if you know any chemistry, acetyl-CoAs in the mitochondria. So you go from, glucose to pyruvate, or actually in this case you go from fatty acids to acetyl-CoA, but it can't go any further. So you'll form those together, and you can form ketones, or that's where they get acetone breath, or the juicy fruit gum, or fruity breath kind of thing. And these can be used inefficiently as an energy source, but it can get you by without glucose. And this is just another picture where you don't have enough insulin, or the insulin doesn't work, then you can basically end up with ketogenesis, or increase of ketones in the blood, leading to ketoacidosis. And so they can check those levels. Glycosuria is the third manifestation, where you have glucose in the urine, which basically leads to high urination, a lot of urination, polyuria, because you get a lot of glucose in the urine. It's going to draw, by osmosis, draw the water in and take the water out. So you have a lot of urination, which basically is then going to lead to increased thirst, so polydipsia. You're going to be very thirsty, and you're then going to drink a lot of water. So one of the indicators is drinking a lot of liquids because you're really thirsty and urinating a lot. Polyphagia basically is where you're really hungry, but you don't gain weight. So you eat a lot of food, but a lot of the carbohydrates, or most of them, are going to go out in your urine. So you don't get a lot of energy, but you're still hungry because your cells are crying for food, trying to be fed, and you just can't get it in there, can't get the sugars in there, and you start losing weight, and you'll get high ketosis. And so it's kind of a revolving door there. Just to give you an indication of why it's so important to control diabetes, is that cardiovascular risk is 400 times normal, and then nephropathy, which is kidney problems, retinopathies, eye problems, infections, because you have sweet blood, bacteria love it, strokes, very high percentage. So it's very, very important to control your diabetes, because you have a high risk of other problems. There are two main types of diabetes. Type 1, it's called brittle because it's very hard to control. Blood sugar levels can go up and down. It's very hard to get it regimented. It's kind of rapid onset, meaning that it's going to come on. It's not something that is very gradual, that you can see coming. It just all of a sudden seems to happen. And normally before your age of 25. That doesn't mean always, but before the age of 25 is when you normally, if you get diabetes, it's normally going to be type 1. That's not always true, but most cases. It's considered to be an autoimmune disease. Basically means that your immune system attacks your beta cells and destroys them. There's some evidence that it could be a viral infection from somewhere that just some people are susceptible to. And then in an effort for your body to destroy the virus, it actually destroys the cells that the virus is in. But it seems to be that the virus will be latent unless there is what they're called a preceptor, where you get sickness or a fever or stress or hormones, something happens to jog your immune system, and then all of a sudden it goes kind of berserk and starts destroying the cells with the virus in them. But the key thing for nutrition is there are no major risk factors for nutrition. I mean, you can't eat too much sugar and get type 1. It is not a nutritional issue until you get it. Now, once you get type 1, then it becomes a nutritional issue. But eating too much food or doing something bad nutritionally is not going to cause type 1 because it's an autoimmune disease. It's another factor. But once you get it, then you have to watch and maintain your blood glucose levels, so it becomes a nutritional issue. Type 2 diabetes, now this is a nutritional issue. It is a mild form, meaning it can be controlled a lot easier than type 1. It's gradual onset, meaning that this would be where you would see the pre-diabetes, and then it would gradually get worse and worse and worse. And so mostly in pre-diabetes, you're trying to control type 2. And this was used to be called adult onset, but now it's not, because the population, adolescent population is increasing in the percentage of individuals who have type 2. It's a progressive loss of the beta cells, number one, which is not destruction by the immune system, but loss of function because of possibly overuse. And then malfunction of receptors, or called insulin resistance. So your cell receptors don't receive the insulin, and so even though you produce enough insulin, it doesn't work. So it's not an insulin problem. Type 1 is an insulin production problem. Type 2 is not. It's more of a insulin cell resistance problem, or a loss of beta cells progressively, a chronic kind of gradual loss of the beta cells. Risk factors, gestational diabetes is diabetes when you get during pregnancy, and what they found is that women who get gestational diabetes have a very high incidence of risk for type 2. So if you do or have had gestational diabetes, you have to be very careful, because your risk of type 2 is a lot higher than the normal population. Also, decreased GLP-1, amylin decrease, or resistance are also hormones that can have been shown to be risk factors, as well as the insulin resistance kind of thing. Some main risk factors also is obesity, and mainly the central or visceral. So this would be obesity that happens around the abdomen, but it's underneath the skin. Basically, you have abdominal obesity, which would be in the subcutaneous layer of your skin, and so you would get that filled up. So that's the kind of the blubbery one, the kind of the jiggly kind of fat. But you'll notice people who have big bellies, but they're hard, and this is when fat develops underneath the muscle, with around the intestinal regions, in the greater omentum and around in there. And so it pushes out on the muscle, so they get a big round stomach, but it is hard. It's not jiggly. And this is the main one. So the non-jiggly one, or central visceral, is the highest risk factor that can lead to insulin resistance. It can lead to post-receptor defects, which basically means that the signal gets to the receptor, but the relay of proteins inside the cytoplasm of the cell never reach the nucleus that basically is going to be the instructional area where they actually make the insulin transporters that are going to be embedded into the plasma membrane. And then over time, if you because your cells are going to be continually crying for insulin, because if they're not getting sugar, the response of the cells is, hey, we need to tell the liver or the pancreas to make more insulin. And so you can get hyperinsulinemia because of this, because the cells are crying, and the body's response is, well, I guess I better make more insulin because I apparently didn't make enough or something. And it makes more insulin, but the insulin doesn't work. And so you get hyperinsulinemia that over time can stress the beta cells and cause them to decrease. And then there is some some evidence that I've heard about where, if your adipose cells get bigger, it can affect the shape of the receptor in the plasma membrane for insulin, and if it affects it enough, then the insulin will not fit into the receptor. And so then if you lose that weight, the cell size gets smaller, the receptor gets back to normal, and the insulin works. So you'll find that in a lot of cases of type 2, if individuals lose weight, they can control their type 2 diabetes by that way, but it's a possibility. So those are 4 possible mechanisms by which insulin or type 2 diabetes could be formed. This is just an indication that type 2 diabetes is one of the fastest growing problems, and it's totally related to obesity and insulin resistance, because you noticed on the previous graphic that 80% of Oregonians with obesity have diabetes type 2. So it's a big problem. Just to give you an indication, I don't expect you to remember all this, but the idea is we've got visceral obesity. So this is around your intestines, so underneath the fatty layer of the abdominal muscles. And what it's going to do is create fatty acids. And the excess fatty acids are going to get into the liver and start affecting the liver because they're acidic. And the idea is you break down this visceral adipose tissue before you do the subcutaneous. And so you're going to get there's a direct connection between the cells, the visceral cells, and the hepatic portal vein that goes right up to the liver. And so if you get a lot of fatty acids in there, they're going to affect the liver, which is in turn going to affect the muscle receptors. So both the receptors on the liver for insulin and the receptors on the muscle for insulin are going to be affected, and then they won't work and cause a problem. And this is just another slide that shows that, where you have adipose tissue, you get lipolysis, which you have increased free fatty acids that go to the muscles, increased free fatty oxidation, decreased glucose utilization, increased gluconeogenesis, basically the cells crying for sugar, and so you start producing more sugar, and you get hyperglycemia. So you can actually get hyperinsulinemia, you can get hyperglycemia more because the liver keeps putting out glucose because the cells are crying. So it says, well, I need to produce more insulin to get glucose into the cells, but I also need to produce more glucose to increase the blood glucose levels, because obviously I'm getting enough. And it just, again, becomes a revolving door kind of thing. Again, just another one is showing that elevated free fatty acids are going to affect the liver, increase glucose output, it's going to affect the muscles, decrease glucose transport, so it decreases the expression or production of the GLUT4 transporter, and then reduce insulin, so it leads to hyperglycemia. So that's the idea of visceral obesity. Another graphic just shows that stress, they call it obesity stress, that can produce something called the tumor necrosis factor, which causes inflammation, and with the excess fatty acids, and it causes stress, and that increased stress is going to inactivate the phosphorylation of I think it's serine, which is an amino acid. But the key is the stresses are going to inactivate this, which causes no transporter to get to the plasma membrane. So this would be an indication of post-receptor defects. Okay, so it's not a matter of insulin resistance, it's a matter of post-receptor defects. You can see that the insulin fits into the receptor fine, but after it starts sending the signal and stuff, it's not going to cause any effect, and so you get no receptor in the plasma membrane, therefore no transport of glucose out of the blood. So it's not an insulin problem, it's not an insulin receptor problem, it's a post-receptor defect problem. Some of the complications of diabetes is you can get hypoglycemia. And you can get hypoglycemia if you have a lot of insulin, so you take your insulin shot but you don't eat food. You can get hypoglycemia, and that's called insulin shock. And so, you know, you may take your insulin shot, an emergency comes up, you don't eat breakfast, and then all of a sudden you start feeling kind of hypoglycemic. And we'll go over those things in a second. Hyperglycemia, you know, usually diagnosed before you know you have diabetes, ketoacidosis. So you have a decrease of insulin, but you eat your normal food, and you have increased food intake but decreased insulin, so you get hyperglycemia, and leads to the conditions of hyperglycemia that we've talked about. What is the nutritional therapy? What are the goals? You want your A1C to be below 7%, and you can look up those levels online and just see how they relate to blood glucose levels. Prandial means, preprandial means before you eat. So before you eat breakfast or lunch, then you would want your blood glucose to be. Postprandial be about 2 hours after you eat. You'd want them to be around there. We'll talk about LDLs and HDLs when we get to heart disease, but these, LDLs are the bad cholesterol, HDLs are the good ones, and you heard some about triglycerides. They're getting more and more important, but these are the levels. So if some of you have had some blood tests for cholesterol and stuff, you've probably seen these numbers, but these are goals. Blood pressure, very important because of high risk of stroke. In diabetes, microalbumin, and then BMI, body mass index, less than 25. 25 or over is considered overweight, and so that was when you'd get into the range of possibly being at risk for type 2 diabetes. I don't necessarily need you to know these numbers, but I do want you to understand the risk factors that are important for diabetes. Hypoglycemia. Now, hypoglycemia is low blood glucose, getting it down to the 40-50 milligrams per deciliter range. Stress can cause it, as I mentioned. It could be excess epinephrine over a long period of time. So anxiety, tension. So if you're under fear a lot, if you have stress at your job, that kind of thing can cause hypoglycemia, or it could be a pancreatic tumor, which is why you should not self-diagnose yourself with hypoglycemia. Some people do. They carry around some sugar pills or something, and they say, oh, I feel hypoglycemic, so they take a pill. But it could be a tumor. So you want to make sure that it's not. So it's a manifestation of a disease. It's not a disease itself. You want to go get it checked because it could be something worse than just stress. There's two types. Reactive, this would be where you have, very quickly, 2 to 4 hours after a meal, you get really hypoglycemic symptoms, and I have some slides on what those would be. Mainly, it could be an overproduction of insulin, so you just have an issue where you just overproduce it for some reason. It's just a glitch. And then fasting would be if you haven't eaten for 8 to 24 hours. Now this would be the worst one because it could be a pancreatic tumor that could be affecting you. So again, please do not self-diagnose hypoglycemia. And here's some of the symptoms of hypoglycemia, and some of you may have felt these. It's, sometimes if you're playing a sport or playing basketball or something, you might feel a little sweaty or shaky and just a little kind of hungry, but it's kind of a sicky hungry feeling. You sit down for a while and it kind of goes away. But if it continues or if it's frequent, then you need to go get checked by a doctor. So the blood sugar regulation nutritional care plan for diabetes and hypoglycemia would be pretty much the same because they both have, it's dealing with abnormal blood sugar regulation. Carbohydrate counting, which we will have a little assignment on later is the main thing that patients will be sent home to do. They will be taught how to do carbohydrate counting, because carbohydrates are what's going to become sugars. Proteins aren't, fats aren't. And so you want to watch your carbohydrates. And so you will monitor how many grams of carbohydrate you would eat per day. And then you will have a certain amount that you can eat per day. And it's based on kind of a carbohydrate 15-gram amounts. And you'll have an assignment on that, and we'll go over that a little bit more in detail. Also, something called the glycemic index, where you have foods that can raise the blood sugar levels very fast, and they did a comparison with white bread, and we'll look at those in just a little bit. But it's not something you'd send a patient home with, but it's something that a dietitian might look at a patient's food intake and look at foods that might have a high glycemic index. And so what you don't want as a diabetic or a hypoglycemic is have a big rush of sugar into the bloodstream all at once. And so you'd want low glycemic index foods. And then glycemic load would be just basically, you may have a food that has a high glycemic index, but if there's not a lot of carbohydrate in the food, then it's not going to have not be a very big factor. So it'd have a low glycemic load on that. So just as an indication, if we look at, say, a corn tortilla has a glycemic index of 52, but it has a glycemic load of 25, which is considered high. But if you look at watermelon, it has a high glycemic index, but since there's not much carbohydrate in it, it has a very low glycemic load. So they kind of you can look at glycemic index and glycemic load of foods, and look at those, because you can, one of the surprising ones, especially baked potatoes, has a very high, kind of a high glycemic index, but also kind of it's kind of a low glycemic load, I guess. But anyway, so sorry, you might run into where you're talking about glycemic index and glycemic load somewhere. And so I just wanted you to know what the difference was. You don't really need to know these numbers, but just what is glycemic index, and what is glycemic load. If you know the definitions, you should be fine. Protein, 15 to 20% of your diet, is very important to keep your protein levels up, because your immune system has kind of been affected. So 50 to 20%, lipids right around 30%, but low saturated fat, low cholesterol, and then these. So keep your lipids low, because you don't want to get obese, and you don't want a lot of saturated fat, because of its effect or risk for heart disease, and cholesterol also. So keep those low. Multiple feedings, you want to manage especially your carbohydrates throughout the day. You don't necessarily want to eat 3 big carbohydrate meals a day. You want more like 6 or 8 carbohydrate meals a day. So you can kind of even out the carbohydrates and the amount of sugar that gets in your bloodstream throughout the day. It should be a no-brainer to maintain reasonable weight, especially looking at type 2 diabetes. And then, because alcohol has an effect on the liver and the pancreas, you kind of need to limit yourself to 1 drink, and here's the limits on those kind of things. So I hope this gives you just a little bit more information about diabetes and blood sugar regulation and hypoglycemia. And we'll continue our discussions on different diseases as we go through these